Hi everybody and welcome. My name's Irene Mooney. I'm the CEO of MYVISTA, an aged care provider of residential aged care, home care and retirement living. And I'm very pleased to be able to be presenting our Advanced Care Planning series to you. With me today I have Carol Douglas. Welcome, Carol.
Thank you, Irene, for inviting me.
That's our pleasure. And Carol's background is a nurse practitioner and also is a board member on MYVISTA's board and provides great clinical insight and governance for the board and for the organisation. Shall we get started, Carol?
Great, love to.
Carol, give us a bit of an idea about how we can empower families and loved ones to be active participants in advanced care planning conversations.
I think with everything to do with advanced care planning, Irene, you have to start with conversations that reflect from a space of kindness, empathy and compassion. So we have to understand that this is the person's care plan, advanced care plan, and it's important that we're reflecting their views and their values in the process. So when you talk about families, how we can empower them, some family members are not in tune with doing this, having this conversation, but some families members do it really well. And I think it's really important that the families respect those roles within their family. And I think the family could also really take a cue from the individual. Sometimes individuals start a conversation and the families need to pick up and run with it. So there's opportunity to really understand the process. And one of the other key factors here is to ensure that we're talking about living well. People live right up to the moment they take their last breath. So it's not all about the dying phase. It's also about the living well.
Yes, and so would you say, Carol, that these conversations need to necessarily be when somebody's acute or suddenly ill? Or do you think we should encourage people to maybe start them earlier?
Oh gosh, the starting earlier, the earlier the better.
Yep.
So I've had my conversations with my family members many years ago, as you would expect. But at the end of the day, the sooner we have these conversations, the more insight. But also the conversations can change over time. So don't just assume because you've had a conversation with someone that it doesn't change. It's much better to do it before you go into residential care. It's better to do it when the person's cognitively intact and able to have their own conversation and voice their own beliefs. So I think the earlier, the better. Just don't be scared of having the conversation.
So, Carol, in your experience, what are some effective ways to normalise discussions about death and dying everyday residential aged care settings?
First point is don't use medical jargon. Right? I prefer to use the words death and dying. I have had wonderful responses from families and who've said to me, Carol, you're the first person that's told me that my dad is dying. And that's and with tears in their eyes, because they actually many families want to have the conversation. So I think that being really clear that we're just wanting to find out what the person wishes for, what their preferences are. So don't be fearful of any part of the conversation. There's one way I sort of sometimes if I think the person is going to not respond as well to death and dying, I might say, I'd really like to chat to you about how we provide your mum's care well, or how your mum thinks that she would like to her end of her life to look like, so that we can plan and fit in with her values and beliefs.
In that discussion from people as at MYVISTA, we have a range of migrant, different cultural backgrounds, different heritage. How does that happen and how does that get normalised for that individual?
Very, very important question, Irene, because first of all, it's really important that we as staff understand someone's cultural background. And traditionally we would be able to understand what those cultural beliefs might be. But what we can't do is assume, because there are many individuals who don't necessarily align their values and beliefs to what tradition says. So I think having the conversation and asking the person, what are their values and beliefs?
Do you think involving and having maybe interpreters or translators involved in some of these discussions is useful?
Very useful, very useful. As long as we keep it personal. So as long as we have the trust and that relationship to have this very personal conversation, and that interpreter isn't engaging in just simplifying the conversation. Yeah.
Yeah, I think that's really important. And I can see, particularly at MyVista, that cultural diversity, and as the generations keep changing, and as we're getting different generations of migrants or individuals come through, their expectation of that language is different, isn't it?
It is. It is. And I think it's actually asking the questions first. So the big point there is don't assume. Don't assume anything, but also really understand the person and their life and who they were and who they are now gives you some insight into that, building that relationship and trust as you have the conversation.
As healthcare professionals, how can we best support aged care staff to talk with customers and family about death and dying and advanced care planning?
Don't bring in jargon. Talk about the person and their life. And I often suggest to staff that they ask families how they have seen their loved one's healthcare condition over the last 6 months. And what do they think that might look like in the next 6 months? Because that helps the family reflect on how mum or dad or their loved one has progressed over the last 6 months and then moving forward. There's another 3 key principles I use in communication, and that's ask, inform, and ask. So I say to staff, ask the family or the loved or the person the question first. Then answer the question, and then ask, how do you feel about that? And keep the cycle of conversation going through this process of ask, inform, ask.
At MyVista, a lot of our staff have different cultural backgrounds, and they come with their own set of norms around death and dying and how they might have seen it or be involved. How do we help them to help our customers and avoid falling into what they believe death and dying should look like rather than what the individual would like?
So the first key principle is don't bring your own values and beliefs to the table. This is about the individual, not about yourself. And you can't use your own experiences in these settings sometimes. This is about understanding the person, building that respectful conversation, having an understanding of who that person is, who they have been all their lives, and understanding the family dynamics. So the more you know about someone, and the more you know about their health condition and how they're progressing yourself, then that makes the conversation easier. But just don't bring your own values and beliefs to the table. This is about the person that you're talking to.
And Carol, with that, what if someone has dementia or is cognitively unable to have capacity or insight? Should they be at these discussions around advanced care planning?
Um, in most cases, I'd like to say yes. Right? I would like to assume that's a good place for the person to be. Having said that, if this sitting in a conversation is going to agitate them or cause them stress, then they don't need to be there. But we always have to assume that anybody with dementia has a capacity to be part of their decision making, and it's forefront of everything we do. So upfront, yes, if they can be, unless it's going to cause them some more added stress.
And my last question to you is, how can you help families balance respecting a loved one's documented advanced care wishes with emotional challenges of making decisions during a crisis or an acute health episode, particularly if the care plan feels difficult to uphold by the family.
Oh, yeah. And we've seen this on too many occasions because when these situations, if the care plan is not clear and it hasn't been communicated across families and everybody isn't on board with the care plan, then it will potentially cause a fearful reaction. So families panic and they, out of good intent, want to do the right thing. But we lose the context of what we're trying to achieve here, and that is the best possible outcome for the older person. So when we don't have those clearly articulated care plans right up to the last, you can have a crisis happen where a situation. Now, if you have a clear plan, that plan can be instigated and put into action, and the person follows that journey in a comfortable, respectful, dignified way. But the risk of everybody not being on board and families challenging those decisions can cause confusion, fearful reactions. It can cause suffering and loss of dignity.
Thank you. I really appreciate your insights, Carol. And is there any last comments that you'd like to leave us with about advanced care planning?
Don't assume that people don't want to have the conversation. I haven't met a family that in some way of translating how we're having this conversation that haven't been happy to proceed through the conversation, and in fact have been enlightened and felt much more relieved to know exactly what the end of their loved one's life may look like. So have the conversation.
So I guess the things I've taken away, there's a lot there from Carol, is don't assume. And as aged care providers and staff, we can often make this easier by opening the conversation and allowing others to be heard, particularly the individual, and also speaking without medical jargon and clinical terminology in everyday language that the individual would normally talk in, and if needed, have others to support them or a translator. And on that, I'd like to say thank you, Carol, and we'll finish there.
Thank you very much.